So when we look at a whole group of patients with Klippel-Trenaunay syndrome, 2/3 of patients will have all 3 features. 1/3 of patients will only have 2 out of the 3 features. Most cases of KTS affect the lower extremity, so 70% affect the legs in patients. The upper extremity is affected only in about 10% of overall of patients with KTS. It may be unilateral or bilateral. It can affect the head and neck and can be truncal, and as we know, it can occur in association with other conditions such as Sturge-Weber syndrome. And it's very important to identify these patients as well. Before I forget, you can get KTS affecting the trunk. And so, for example, if you have a patient with KTS and you see that they've got a capillary malformation over their abdominal wall, for example, it is likely that they may have underlying visceral disease with the abdomen due to KTS. And so that's important. In KTS, actually, you can even get visceral disease without having a cutaneous abdominal wall capillary malformation. And one thing that you can get actually usually later on is actually occlusion of the portal vein, leading to cavernous transformation of the portal vein. So if you find a big spleen in patients with KTS, it may be because they've actually got a portal vein occlusion. That's not a feature in KTS. So the port wine stain. So port wine stains, there are 2 types. The typical geographic stain, as in this boy I showed you previously here, and it's called a geographic stain because it looks like the geography of an island. You can see the island floating in the sea, and you can see the edges of the island. There are port wine stains which are less well defined and known as blotchy, as in this child here. What we do know is that if you have a geographic port wine stain, you're more likely to have an underlying lymphatic malformation within that affected extremity. The little black blebs, the dark blebs, the background of the port wine stain, are actually lymphatic malformation. They are little lymphatic vesicles. And you see this, and they can bleed from time to time. They usually stop spontaneously. They then recur. They sometimes, once they've bled, they sometimes disappear, or what look clinically as though they're going to disappear, and then they come back a few weeks, few months later. The port wine stains in babies usually progresses, and as you get older, the stain at the capillary malformation grows, it gets thicker, it gets nodular, and can become more troublesome. So that is always important to remember. So regarding extremity overgrowth in Klippel-Trenaunay syndrome, it probably is the most variable of the 3 cardinal features which I mentioned. The extremity overgrowth can affect, for example, in this patient with a leg affected by KTS, it's affected the girth, as you can see in comparison to the normal leg, and sometimes it can affect the length of the leg as well. And what we know is that progression is sometimes unpredictable, and it's really important with patients who have KTS is to estimate their leg length discrepancy, if they have a leg length discrepancy. And normally what we would do is we usually do some form of X-ray follow-up once they've passed the toddler age group. So before that, we don't do any imaging for their leg length. We measure them clinically. We still measure them clinically even after the toddler age group. We don't just go to X-ray, CT, or to MR leg length assessments. And what we know is that if you have a discrepancy less than 2 centimeters, so if the longer leg is less than 2 centimeters longer than the normal leg, then usually functionally this is quite minor. It's when it's actually getting to 4 centimeters and more that it really is a problem, and then the surgeons would consider an epiphyseodesis. But they would do the epiphyseodesis usually, for example, in a leg either at the upper tibial epiphyses or the lower femoral epiphyses. And they can judge, they can time that by actually looking at the leg length over time, and also doing a bone age, and they can predict when they should do the epiphyseodesis. And what we know is that the leg length discrepancy does not progress after physeal closure. And we, like all vascular malformations, when a child actually stops growing, the vascular malformation stops growing. So the venous malformations will stop growing, and the arteriovenous malformations will stop growing, but they do not regress. And certainly with arteriovenous malformations, the hemodynamic changes can continue, and it really can be troublesome. So the reason that the leg length discrepancy doesn't progress, we know because the bones are fused, but this actually just mirrors the growth and the changes we know with vascular malformations once you stop growing generally. Sorry, on this X-ray, we can see on scanograms are very useful, and whether they're done by conventional X-ray or CT or MR, hopefully if they are done by MR, then you have no ionizing radiation, but sometimes it's not always so easy. In our hospital, they use actually CT scanograms. And the most patients, if they do have a difference in extremity size, it's usually the affected extremity is larger than the normal extremity. However, infrequently, the affected extremity may be smaller than the normal extremity. That is the exception rather than the rule. And in Klippel-Trenaunay syndrome, and as I said, those with geographic stains certainly have an increased risk of underlying lymphatic malformations. Then there are a group of abnormalities affecting the lymphatic system that we see in Klippel-Trenaunay. They may have a disturbance to lymph flow in the limb, they have lymphatic malformations, they can have leakage of lymph, and in fact I have one patient and he's a teenage boy and he pours out lymph from his foot daily. He fills his shoes with foot. We've tried pneumatic compressions, other types of compressions, nothing works, and he keeps going like this. He gets admitted to hospital usually about once or twice a year with cellulitis as well. They can get infections, obviously, and cellulitis, as I said. And this is one patient, and sadly she died. She was 6 years of age, and she died this year. She came into our emergency department septicemic and died. And when she initially presented, people had thought that she may actually have had a pulmonary embolism because venous thromboemboli are more prevalent in Klippel-Trenaunay syndrome than in the normal population. And she has extensive lymphatic disease in her leg. You can see in her port wine stain she has some bleeding, and this is in her leg. This was chronically infected. She was actually on medicinal honey, and our dermatologists were looking after her. And also this is another child and teenage girl who used to come in with recurrent buttock pain, and she has Klippel-Trenaunay syndrome, and in her buttock, extending into the pelvis, are these macrocystic lymphatic which used to get repeatedly infected, and on one occasion they bled, also causing pain. So skin bleeding can be a problem from cutaneous lymphatic malformations in Klippel-Trenaunay syndrome. Here's one girl with this perineal lymphatic malformation, and this would bleed quite profusely several times a day. She's having real trouble. Our surgeon actually removed this twice, and within 1 month of surgery on both occasions this recurred. She actually then went and had carbon dioxide laser, which has actually flattened this and has halted this right now, but we think that things will recur eventually. And then we had another girl with some destruction to some tissue in her toes, which was causing bleeding, and she actually went on and had some grafting done, and things have improved since then. But surgery is fraught with problems in the post-surgical period because of problems with healing because of the lymphatic disease.